Ladies and gentlemen, esteemed guests, and fellow healthcare professionals. For our session today, we have with us Dr. Neerja Gupta, a breast surgical oncologist and oncoplastic surgeon. She's a visiting consultant in surgical oncology at Akash Healthcare Dwarka and Dharamshila Narayana Super Speciality Hospital, Apollo Spectra, Karol Bagh. Dr. Neerja will enlighten us with her insights into selecting appropriate patient profile for breast-conserving surgery. It's a wonderful having you with us, Doctor, today. And thank you for taking time out to share your thoughts and inputs with MedSynapse medical community. Welcome.
Thank you, Harshita, for the kind introduction. And as we're going ahead with the talk on breast conservation surgery, I just wanted to enlighten or talk in brief about what is breast conservation. So when we get a patient who has been recently diagnosed with breast cancer, and we offer various surgical options. So one is a breast conservation surgery. I think mastectomy is something which every one of us know about, but breast conservation is something where we don't remove the breast, but we do the oncological, follow the principles in terms of removing the tumor and using a safe margin around. So how safe is breast conservation has been a point of debate, but with various studies and international guidelines, everybody knows that in select patient groups where we have a definite criteria which we are going to talk about today, how to select it. So with that particular selection criteria, we can very well go ahead with breast conservation with full outcomes, and it is not going to affect the mortality, morbidity, or long-term survival of the patient. But the selection of the patient has to be very, very pertinent, very, very perfect. So that is the reason we are going to talk about how to select a patient for breast conservation. Right. So how to select this right patient profile. So when we talk of patient profile, it's not just the tumor characteristics, the patient herself, it's the family as well. And it is about how imaging perceives the patient's presentation. So we'll see in all the subsequent slides how we actually look at a patient when the patient comes to us while deciding for a breast conservation surgery. So basically, over about a century, when it was a Holstein era, everybody was doing a mutilating surgery for the breast because they thought that it is the breast which is sending all the systemic disease. So they used to remove the breast and the pectoral muscle, and the surgery was very, very radical, actually very traumatic. But then, over to the next, in 1950s era, when you come to 1950, they started being a little conservative in the terms that they started preserving the muscle. The breast conservation theory came from the spectrum theory. So the spectrum theory is basically derived from the works of Fisher and others, where they realized that removing the breast is not the kind of surgery which will ensure the patient's survival, but it's just that you remove the tumor, control the disease, have a good local regional control, so you will be able to safeguard the patient. So introduction to the concept was brought about in Milan, where they said that complete removal of the breast tumor with a concentric margin of a healthy tissue, which is performed in a cosmetically acceptable manner, and it has to be followed by radiation is best. So we have to remember that breast conservation always comes with radiation, and both of them make each other comfortable. The treatment there is no substitute for radiation. Whenever conservation is done, it has to be followed by radiation. Now, talking of when to do a breast conservation and when not to do a breast conservation. So breast conservation you can do in all the early cases and in select advanced cases as well. So what happens is that breast conservation in early stages can be done with small tumor, but then there are certain do's and don'ts. The don'ts are, it cannot be a tumor which is lying in different portions of the breast. That is, it cannot be a multicentric tumor. So multicentricity means being in different quadrants. In these cases, the radiation patterns become difficult, and a lot of studies have conflicting results, but still it is considered as a contraindication, a relative contraindication, not to do a multicentric tumor conservation. And also the positive margins after excision. So once you do a conservation means remove that particular area with a good margin, you send it for frozen, or in certain cases when you don't have a frozen, you send it for a hysterectomy. But if the margins come out to be positive repeatedly, maybe once, I would say even once if it comes out to be positive, and it has done in a diligent manner, it is a contraindication for a repeat surgery, because there must be something missing in your interpretation, your judgment, your decision. Maybe the imaging was not right, maybe the clinical, judgment was not right. So if you have a positive margin after excision and a big tumor, please don't attempt it. Advanced stages, certain cases you can do, but then there are select cases which are not very high risk, which have responded well to chemotherapy or any neoadjuvant treatment. They may be the candidates for conservation otherwise. Now, access to radiation, you have to discuss with the family. The treatment is not just the tumor that you're looking at. Your focus is on the entire family. So the patient is not compliant, patient is not ready to come, but the family doesn't have an access to that particular institute, cannot come repeatedly because radiation will take time. 3 weeks, 5 weeks, depends on the kind of radiation plan. The shortest one happens for 3 weeks. Otherwise, the standard one goes for 5 to 6 weeks. So if they can't come, there is no reason why you should, take the patient for consultation. Again, certain situations where there is collagen vascular diseases or even scleroderma or rheumatoid arthritis, it is a total contraindication for the simple reason that scleroderma and all these situations, all these conditions, they flare up during the radiation. So these people are not given radiation. For collagen vascular diseases, the radiation toxicity becomes so high that you don't give radiation in such patients. So these are the absolute contraindications for a breast conservation. A diffuse microcal means you have a widespread DCIS within the breast. So this widespread DCIS usually is a calcific one, but sometimes even the non-mastic enhancement that you see on the MRI, it could be a component of a non-calcific DCIS. So if you have a diffuse microcal, do not go ahead with a conservation because you won't be able to get good margin. And again, a wide area of excision will require a wide area of replacement as well. For the first and second trimester, it becomes difficult to subject the patient to breast conservation, especially the first trimester, because if you are taking the patient for conservation and you have to give radiation, and after the surgery in the first trimester, she lands up into a situation where she has to receive radiation in the final trimester, which definitely becomes difficult. So, deciding for breast conservation in early pregnancy is also one of the contraindications. BRCA 1 and 2, directly I will not say is a contraindication, but the fact is, with different studies, it is known that the local recurrence rate, if the patient is not receiving adjuvant chemotherapy, is nearly about 26%. But with chemotherapy, it is reducing to half, about 13%. So again, the entire discussion of undertaking or not undertaking a breast conservation surgery will rest on the patient's, understanding of the entire disease and the discussion that happens between the surgeon and the patient. A leaf wrongness or a TP53 gene genetic mutation, one that comes out when the patient has a very strong family, history, and after evaluation of the family history, you realize that the patient needs a genetic consultant for further evaluation. So she goes to the genetic consultant and they draw a pedigree, they evaluate the patient in terms of computerized models and the risk factor is determined. So after that, the patient may be asked to undergo multi-gene panel in which she may turn out to be a TP53 gene positive. And if this is the situation, then definitely radiation is not a good given from TP53 negative. So we just to understand, this was just to understand in medical terms where we actually do not propose breast conservation. And we all know breast conservation means a limited surgery, so it definitely gives a good appearance, function, aesthetics. But as I said, the disease survival is same as MRM, and quality of life and psychological advantage is definitely there. But this is also, with various studies, the results are varied. So, Page's disease was one which was involving the nipple and areola. It was used to be considered as a contraindication, but now we have come to an era where we do a central quadrant excision and do a reconstruction at the same time, and it doesn't affect the survival in any terms. So basically, if you can achieve a good margin, you can very well go ahead with the central quadrant excision. The cosmetic effects are definitely good, avoids any reconstruction because you're not doing a mastectomy. And for a patient who wants a good aesthetic breast, despite the treatment, surgical treatment, she wants a reconstruction, she wants an autologous or maybe an expander, you can avoid that. In case you can provide a local, replacement from the adjacent chest wall tissue and do a breast replacement and the volume replacement with Oncoplastic. So definitely minimal excision is definitely favorable, especially when it comes to small children. So what are the reasons that the local failures happen? They do not happen because of the disease or because of the treatment modality per se. But the main reasons that happen is the inadequate judgment, or the failure to judge, maybe clinical, maybe imaging. So we have to look at certain factors where we talk about where there's a likelihood or where you anticipate a recurrence in the local lesion. So if the excision is inappropriate, suppose you're not getting good margins, then definitely it is a local failure, despite the fact that you will give radiation to the patient. Then inappropriate marking. So doing a conservation needs a very well planned preparation of the patient. The patient has whatever is the tumor size, and you're planning to give the patient neoadjuvant, because after that the tumor might disappear as well. So once the tumor vanishes, you're not able to mark it, or you're not able to localize. So the entire thing has to happen before the start of the treatment. So what you do is you do a random marking. In the sense, random marking means what I mean by marking is doing with ink, which is could be any tattoo ink or the ink that is used in radiation department. So you do a subdermal injection of about 1 ml at 4 points of the tumor in a cruciate form. And that tattoo you can see very well on the skin. The darkest of the skin will also show that. So one is a inking, the subdermal injection. And the second thing is placing a clip in the ultrasound department in the center of the tumor. So if these two preparations are not done properly, definitely your removal, there is a high likelihood that you miss the exact tumor area, right? In that case, there's a chance that the tumor comes back at the same time. Again, if you have an discontinuous cell expansion from primary in the form of patchy, infiltration near the tumor, it may be just start from the maybe from start in the form of DCR, which doesn't respond to chemotherapy, or it may be a patchy response of neoadjuvant chemotherapy. So whenever these patchy lesions are there, it may be difficult to actually identify the footprint of the tumor. In that case, either you do a bracketing with wires in ultrasound from the beginning, so that you can identify what was the area where the tumor started, and so that you can remove that entire area in case it needs. But you have to have a right footprint of the tumor, and following subsequent months, you should be able to identify how the tumor is resolving. If it is resolving in a patchy form, then you go back to the footprint and remove the footprint, because you don't know exactly what are the areas which are still involved. But if it is a very regular form of concentric resolution or response, then you can very well just pick up that clip, go around, and take a regular margin, or healthy margin around it, send it for frozen. And I think that is the best thing about you. Nothing replaces. Now again, imaging is missing. If you're not missing something on imaging, that also is leads to local. And inadequate preparation, not inked, not clipped, and clip not actually being localized. I've seen a lot of cases where it is very difficult to pick up the clip after the neoadjuvant chemotherapy is complete. A small clip placed might just vanish somewhere. So you may not be able to localize again that situation. So that is the reason we do double thing. We ink and we place a clip for double confirmation. So you know where the tumor started. So again, this also conforms to leads to local failure after this. In an incomplete treatment, patient is not taken radiation, definitely that is incomplete. Again, clinically, to start with, if you see a very widespread PDO, right, or a diffuse induration or erythema, then definitely these are the locally advanced situations. adherence to the skin, ulceration, adherence to the muscle. These are all locally advanced cases where you have to look into the real necessity of doing a conservation. Why do we want to do a conservation in this case? Is the patient too moribund to undergo MRI? If that is a situation for a suppose wheelchair-bound 75-year-old lady, then you can very well go ahead, do a conservation. If you can do upfront or you can do after neoadjuvant therapy, you can do that. So if the patient is very favorable kind of a tumor, hormone positive, many a times the elderly will respond only to the hormone therapy and the tumor will vanish. You can very well wait for that time and then decide to undertake a surgery, just the wide excision, and followed by radiation. That is the protocol. It is an elderly molecule. So skin nodules, no. Skin nodules, definitely, if there are skin nodules, this is a contraindication because it suggests widespread disease in presence of a primary tumor. Nipple retraction with a distant tumor location. Suppose the tumor is somewhere in the upper outer quadrant and still she has a nipple retraction, just don't overlook that. That has happened. What happens is that tumor cells will be infiltrating the ducts and it will show the nipple retraction. So you have to scrutinize the situation, go ahead with an MRI and other imaging modalities, confirm that the nipple area is not infiltrated or not involved with a tumor. Otherwise, the entire quadrant is supposed to be involved with a tumor because there is a nipple retraction and presence of a primary intestine. Nipple discharge. Sometimes patients have a bloody nipple discharge and there is a tumor there, far away. So this could be a concomitant too, but most likely it's a single thing which is involving both. So again, your area of concern becomes bigger than the one you started. It's not just the tumor, it's the nipple as well. So you have to think logically that way and evaluate the central point. How does the imaging characteristics, make you reconsider the decision of BCS? So if there are multiple foci, as I said, multiple foci microcalcifications of DCIS, they will not go away with chemotherapy, and you will see them right on the spot, whether on a mammogram or maybe DBT, a digital breast tumor, where you have overlapping glands. In that situation also, your DCIS will be very well visible. So multiple foci, widespread, patchy areas, there is no reason why you should be affected. Again, as I said, the non-massive enhancement, very well seen on MRI. So these patients will be either the ones, NMLE could be most likely, they will detect, once they see the NMLE, they will be able to predict which kind of NMLE, whether it is really considerable. If it is considerable, then definitely this is the area which needs to be excised as well. So you can go ahead with BCS if you are able to involve that area with a normal margin. Again, a ductal enhancement with symptoms, as I said, pathological nipple discharge, bloody discharge, and showing ductal enhancement, you reconsider whether you should remove just the tumor, because again, you have to come back to the nipple area and see it, in depth, whether this is an involvement or not. Residual disease after chemotherapy, if there is a patchy response, I've already spoken. So if there's a patchy response, you should know the footprint where you started. And if the bracketing is not being done, and you see patchy nodules there, I don't think it's a good patient for this. Non-visualization of clip. If you miss the clip, you can't see the clip, please don't go ahead with the conservation idea. Again, the satellite nodules seen on MRI, they are also a deterrent for breast cancer. Multicentricity, and nodules have not responded to chemotherapy, and they suppose you start with something, planning of a BCS, and a nodule which possibly has been overlooked or has been seen on MRI but was seen like a -3, indeterminate, now disappears after chemotherapy. So if it disappears after chemotherapy, go back to all the images, discuss the imaging, because if it has disappeared and responded the way the tumor is responded, then you take it as positive. So this also needs to be out. So now if it is in a different quadrant, it's a multicentric. So again, you go back to the same thing, whether to do a conservation or not. So when we do a conservation, we do different images, where we do a mammography, ultrasound, MRI, and sometimes a DBT to define the characteristics of the breast and to deeply look into the breast sites where overlapping is seen and mammography is not very well depicted. So These are the imaging modalities we use. It says that MRI gives a response to neoadjuvant chemotherapy better than the traditional method. Even if, despite the physical examination, clinically, if you feel the tumor is not as responded, MRI will give you a better overview about the extent of the tumor than normal. So MRI has definitely value in improving the accuracy of the uncertain foci, whether it's calcific DCIs or it may be a non-calcific DCIs, which presents in the form of non-mastoid enhancement. So MRI is definitely more accurate with accuracy nearing to 84% with MRI and as to 73% in mammography. And MRI and sonography combined would give you identification of residual disease close to 100% as compared to only 86% with mammography. What are the components of decision? So one is eligibility of tumor. If the tumor is small, excisable, again you can fill it with an oncoplastic, definitely. You can go ahead with an upfront surgery if the tumor is a hormone positive small tumor and clinically node negative. So you can go ahead with a conservation, that's not an issue after the stage. And if the imaging also conforms to the same, the counseling and the patient decision making is an important judgment. As I said, the BCS breast conservation surgery is not just the treatment of the tumor, but is the treatment of the patient and the family as a whole. So if the patient is ready to undertake a mastectomy and the family is also very, very happy, then there is no point, going ahead with the discussion of breast conservation, because both the surgical modalities are good and they are both of them are they're going to be of the same outcomes and good survival in the future. So what is the locally advanced? Definitely, we have to have a discussion of what I said. Again, the preparation of the patient, inking, bracketing, wiring, clipping, all these are required, and you have to localize that tumor before you go into the conservation plan. So in locally advanced, you have to evaluate the response and mark the tumors with clips and inks before you actually start the entire thing. So clipping can happen after maybe 2 cycles. Sometimes people do it after 2 cycles. Sometimes they do it when the tumor has come down to about 1 centimeter or maybe 2 centimeter. So it basically needs a regular examination of the patient. So you have to clip before the tumor disappears. Sometimes, most of the times, we do it in the second cycle because that's the point where the tumor is already shrunken. But if you've undertaken a 3 centimeter triple negative tumor and you call her after 2 cycles, it's already vanished. So it depends on the size of the tumor to start with, and that is the way you look at the point of time where you would call the patient for clipping. So ultrasound clipping happens once the treatment is started, but inking happens before the start of treatment. And intraoperatively, we use specimen mammogram. What we do is if the tumor has already vanished, the clip will need a wire to localize it. That wire is placed in ultrasound. And once this is placed, we remove the tumor or the specimen all around and then send it for mammography, the specimen. The specimen will lie under the mammography machine and then it goes to the frozen section to get marked. So this is the screen. This is the BCS specimen, which is marked with, you can see the threads. So all 4 or rather 3, instead of 4, you can mark 3. 2 also you can mark, but sometimes if the thread slips away, then you're missing on a second, the margin. So 3 margins, you mark superior, medial, and lateral, and send it for frozen section. This is a specimen now. You can see the clip right, one of the clips is right in the center, and the clips on the margins are placed after the removal of the specimen to see how far they are from the center, whether you have a good margin or you don't have. So you can place the clips after removal of the specimen at all the 4 margins, send it for a mammogram, and you will know how far they are distant from the central clip which was placed before the start of, during the start. Again, the specimen mammogram, you can see one of the wires in the blue one is quite close to the surgical edge. So again, the clips are placed to determine the margins from the wire. This image before the frozen section report we would know that this needs a revised margin. So the margin which is near to the wire will need a little bit of resection to be free from, to call it a free margin. And second one is the wire is very well placed in the center, and the margins seem to be very, very far off. So the entire specimen will go to the frozen section, and now the pathologist will tell us that the margins are clear or not. So a little bit comment on the margins. So for margins, we take for invasive component, we take the tumor not on ink. So if it is no ink on tumor, that means the margin is okay. But if that's not the situation, then the margin is closed. And again, the focal presence of tumor cells, if you see the presence of tumor cells in at least 3 fields of view of the margin, you call it a focal presence. This also needs to be revised if it's there. The nasal margin doesn't need any kind of revision, but if it's a closed margin or even positive, it needs to be revised. For a DCI, what we consider is a 2 millimeter, and for invasive, it is no ink on tumor, or to say 1 millimeter of margin is given. So once it is done, even for whatever depth of the tumor, most of the times the tumor comes as deep as the major muscle. So for such a deep tumor, whatever is the size, you need to have some filling, some replacement or displacement, for the simple reason that if you don't do it, you will land into seromas or maybe unsightly scar. Because what happens once the cavity is created, the entire skin will be pulled on down to the muscle, and it will create a very unsightly scar. To prevent such situations, Oncoplastic is the new. It is not new anymore, but yes, it is a field which has evolved, and the breast surgeons have very well adapted the Oncoplastic techniques, where they do the wide excision and they fill the cavity with either the breast itself, with the large breast, you just displace the adjacent gland tissue to that area, or replacement in the sense you take the tissue from the chest wall, from the side of the chest, and you fill that area with that particular flap. So Oncoplastic is definitely now a tool that the breast surgeons use, because this is because the plastic surgeons are too busy. So they don't have enough hands doing all these things. They have to look into their emergencies and other more intricate procedures. So the breast surgeons have stepped in, and they have taken this responsibility of doing both the oncological and plastic together. So as I said, it is oncoplastic surgery is a volume replacement and a displacement. So displacement means where you can take the tissue from the sides of the breast, displace it, or maybe slide it into the area where you have already created a defect, and give a good aesthetic form to it. And volume replacement means if you require a larger volume of tissue to be filled into the defect, you will take all it, maybe the chest wall area or other areas where there are good fat folds, and you can use that to mobilize to the area where you need to. A little bit more on the indications and the relative contraindications. So indications, again, when you dissect more than 20%, you will definitely need something there. So you do a oncoplasty. If the breast size is too large, micromastia, you will plan your incision so that the tumor is also included and your breast also reduces in size. And again, if there is severe ptosis or asymmetry, suppose your breast tumor happens in a breast which is larger than the opposite one, you can plan a reduction as well as removal of the tumor, which is called therapeutic lameloplasty. But then in cases where the two breasts are symmetrical, you need a contralateral symmetrization. So you need to reduce the opposite breast as well if you're doing it for the breast tumor. So for large excisions which are inside the thermoplasty area, you can very well do an oncoplasty, but for large sections which lie outside your incision planning, definitely oncoplasty may not be a suitable option. For large tumors which are in the medial quadrant, the filling of the quadrant becomes difficult because the flaps are not easily rotated into that quadrant from the lateral chest wall to that area. So such tumors may be a relative contraindication to oncoplasty. Again, those who are addicted to tobacco or maybe smokers, those who have an uncontrolled diabetes, these are the patients which do not show a good wound healing. So mobilizing a lot, doing an oncoplasty, doing a reduction therapeutic lameloplasty is a relative contraindication. such. If the breasts have been radiated earlier, then again you cannot do an oncoplastic because healing is an issue. Again, the patient's expectation, I would put it as the first and the foremost indication or a contraindication. Because to you, you may look upon the breast in a different manner. It may be very aesthetically pleasing to you, but the patient may be having higher expectations. They may be they may be expecting something like matching breast, absolutely matching breast, which may not be possible. So you have to sit down with the family, patient, and you have to make them understand what kind of breast it is going to look like once your oncoplasty is done, so that you don't have any hiccups later. As I said, breast conservation always comes with a radiation. So a little bit on radiation. So we have external beam and a brachy. External beam means it comes from outside. A brachy means you have pellets placed inside. So just a little brief on what are the kinds of radiation therapy may be offered to patient of BCS. The external beam radiation is where when you do a BCS, you usually radiate the entire breast, which is called the whole breast radiation. And an external boost may be given to the breast cavity, which is called which is in the highest cases, and this is to avoid recurrence. And the boost is usually given after the radiation is always given after the treatment is complete, after the surgery is done, and after the adjuvant treatment has been done. So the schedules and the various types, whole breast radiation, usually the conventional radiation is 5 days a week for 5 weeks, and hypofractionated is a little less where you give larger doses and you accommodate them in about span of 3 weeks. But this has to be select patient which is elderly and node negative, and again a favorable luminal type. IURT means intraoperative. It's basically the area is filled in with the wires or where after the removal of the tumor. And these are all equipment which are used specially and which is definitely not available in the center. But it is done intraoperatively after surgery to remove the tumor. But at the same time, before the patient is extubated, the wires are placed and the radiation is done. Again, IMRT, 3D CRT, brachy, these are different kinds and they are offered to the patient in well-suited conditions. If it's a left side breast, to avoid, the doses to the heart or protect the lungs and the heart, even the proton therapy has been introduced. Although the cost factor does come in. So these are the different types of radiation which come in, step in when you talk about breast. So why breast conservation is it going to improve the quality of life of the patient? Multiple studies have been done in this field in this direction, and there are varied results. Few of the Indian studies, one from the Mumbai 50 patients, but this meta-analysis talking of several studies shows a favorable response when it comes to conservation, where the quality of life they said was definitely better. But there are different studies and varied results. So what we would say is, who will decide breast conservation? If the surgeon decides the patient's eligibility, the patient also has the right to decide whether she needs a mastectomy or a conservation. So she is the one who would say whether she wants a conservation or a mastectomy, because she knows how she would feel after the breast is out or breast is not out for that matter. So she is the one to feel beautiful, and she will let you know whether she's going ahead with a conservation or a mastectomy. If she's done a conservation and she's not able to sleep well because of the fear of disease coming back, there's no point offering a conservation. So this is all about breast conservation. Thank you so much, and I'm open to questions.
Yeah, thank you, Dr. Neerja. This was highly informative session, and I'm sure the audience has benefited greatly from it. And so we do have questions coming up from the audience, which we would like you to take. So the first question is, for patients who may require breast reconstruction, how is this integrated into decision-making process for breast conserving surgery?
So reconstruction or conservation with oncoplastic, they are nearly the same terms, right? When you don't talk of oncoplasty, you talk of reconstruction. So basically, the idea is that the patient wants a good, aesthetically looking breast after the surgery, maybe from the beginning or maybe a little later. If it is right from the beginning and she's a good candidate for conservation with Oncoplastic, offer her conservation with Oncoplastic. If she's not a candidate, then again you have to downstage maybe. If you can downstage the tumor and bring her into an eligibility condition, do that. If not, if she still doesn't fall into that, because sometimes it's a locally advanced, very large tumor, and you are not very happy with the local response, then should undergo mastectomy first, and the reconstruction happens.
Yeah, and the second question is, if positive margins are identified after surgery, what are the strategies for re-excision or follow-up treatment, and how does it impact patient management?
So positive margins, first of all, you should not have positive margins. So all these steps that I just outlined, they are to just to be very cautious, and at every step you have to take care that you don't land into a situation of positive margin. You do a good clinical examination, you do a good imaging, you do a good discussion. So all these things keep happening till you come to a point that you are 100% sure that you don't have a positive margin. But in case there is a default, so if you have a positive margin, again you go ahead, you first understand, you need to understand why there's a positive margin. If for an experienced surgeon, I will not say it is easy to have a positive margin. I mean, you really have to make a lot of attempt because you very well know where the tumor was, and you are doing an excision far and wide. So if you're not having a good, if you are still not having a good margin, that means there could be something which is lacking with the imaging, and this is something which is deficient to start with. So I would say in such a situation, if you want to go ahead with a re-excision, it's not a contraindication that the guidelines say, but the thing is, even if you're doing a re-excision, the point is, why did you default? There must have been something really difficult or lacking right from the beginning. So if you do a re-excision, I'm sure you're going to land up into a possibility. That happens. So this will be a situation where you have a possibility. So please stop there. There is no second re-excision, and you might have attempted once, but second, I would say no re-excision, and it is not indicated. And you just talk to the patient, the relative, not the patient, the relative, and go ahead with mastectomy. And whenever you plan a conservation and you are in doubt, you must talk to the family and the patient before induction that there is this much percentage of chance I might remove her. So she should not have a shock once she gets up from her anesthesia. You should be prepared. In situations where you suspect, so I'm not talking about each and every time, but yes, where you suspect high risk, you definitely have a clinical and an imaging doubt that she might land up into a mastectomy. Prepare.
Thank you, Dr. Neerja, for answering our audience's questions, and thank you for providing your invaluable insights. Thank you so much.
Thank you. Okay, take care, Harshita. Good day to you.
Thank you, doctor. Good day.